Hey everyone, and welcome. Today we are jumping right into a topic that is so important in our daily practice, chronic viral hepatitis. We're going to break down everything you need to know about managing Hep B and Hep C, really focusing on the practical, need-to-know counseling points that you can use at the pharmacy counter. So, let's get into it. So here's our game plan. First, we'll talk about why hepatitis is such a tough chronic challenge. Then, we'll get into the details of hepatitis B, which is all about lifelong control. After that, we'll shift to the incredible story of hepatitis C, the path to a cure. And we'll wrap it all up by zeroing in on our critical role as pharmacists in making sure these treatments succeed.
All right, let's start at the beginning. Hepatitis as a chronic challenge. It's so important to understand the lifelong impact these infections can have on our patients.
Now, to really set the stage, just look at this number, 90%. That's the percentage of infants infected with hepatitis B who will develop a chronic, lifelong infection. Let that sink in. For so many of our patients, this isn't something they acquired later in life, it's a condition they've been living with since birth. That just underscores how vital our role in long-term management truly is. So what exactly are we talking about when we say chronic? Well, the official definition is pretty simple. The virus is still hanging around in the blood 6 months after the person was first infected. And make no mistake, this is a huge deal. If it's left untreated, the virus just keeps damaging the liver, leading to some really serious outcomes, like cirrhosis, liver cancer, what we call HCC, and eventually end-stage liver disease. This is exactly what our treatments aim to prevent.
Okay, this slide is probably one of the most important ones today because it shows the two completely different playbooks for Hep B and Hep C. With hepatitis B, our goal is control. We want to suppress the virus for life. We measure success by getting to an undetectable viral load. For hepatitis C, though, the goal is a cure, total eradication. We measure that with something called a sustained virologic response, or SVR. So remember that fundamental difference, control versus cure. It changes everything.
All right, let's zoom in on hepatitis B and this strategy of lifelong control. The whole game here is to achieve and maintain viral suppression, basically to put the virus to sleep and stop it from causing any more liver damage.
So, how do we do it? Well, the go-to drugs are a class you're definitely familiar with, the nucleoside analogs, or NAs. And the really great news is that the newer agents have a super high barrier to resistance, which used to be a massive headache with the older meds. The big three you'll see on prescriptions are entecavir, tenofovir DF, and the newer version, tenofovir AF. Now this is your quick reference guide for counseling. For entecavir, the #1 point is it has to be taken on an empty stomach. That's crucial for absorption. With tenofovir DF, TDF, you've got to be thinking about potential kidney and bone issues. So we need to make sure they're getting their serum creatinine checked. And then you have tenofovir AF, TAF, which is fantastic because it has a much better safety profile for the kidneys and bones. And of course, while it's pretty rare, always mention the signs of lactic acidosis with any of these agents.
Okay, everyone listen up. This is without a doubt the most important adherence message you will ever give a patient with hepatitis B. This is not a medication you can just stop. If a patient suddenly stops taking their meds, the virus can come roaring back, causing a massive flare-up that could destroy their liver. We have to be crystal clear. This is a lifelong therapy. They should never, ever stop it unless their specialist tells them to. All right, let's shift gears. We're moving from lifelong control to what is honestly one of the biggest medical miracles of our time. Section 3, Hepatitis C and the path to a cure. We have gone from just managing a horrible disease to completely eliminating it from the body, thanks to these amazing drugs called direct-acting antivirals, or DAAs.
Okay, quick clinical pop quiz. Your patient walks up to the counter with a new script for a DAA, maybe Mavorette or Epclusa. Before you even start running it through your system to check for drug interactions, what is the one single test you absolutely have to make sure has been done?
And the answer is, you have to confirm their hepatitis B status. This is not optional. It's a massive safety issue. If you start a DAA in a patient who has an active or even a past Hep B infection, you can cause that sleeping virus to wake up and reactivate. And that reactivation can be incredibly severe, even deadly. It's a non-negotiable safety check before dispensing, period.
Okay, drug interactions. With DAAs, this is where we really earn our keep, right? These drugs have a ton of potential interactions. You need to watch out for strong P-glycoprotein inducers like rifampin. That's a hard stop. The protease inhibitors are sensitive to CYP3A4 interactions.
Big one at the counter, acid reducers like PPIs can tank the absorption of lidosavir or valpatisvir. And of course the big one, amiodarone with sofosbuvir can cause life-threateningly slow heart rates. We are the final safety net for these.
The great news is you don't have to memorize all of this. Here's your secret weapon, the University of Liverpool's Hepatitis Drug Interactions website. Seriously, bookmark it, put it on your desktop, use it for every single DAA prescription. It's the absolute gold standard and will keep your patients safe.
Let's do a quick compare and contrast of the two regimens you'll probably see the most. With Mavorette, the key counseling point is simple. Take it with food. A huge plus is the short 8-week treatment course for a lot of patients, and it's safe to use in anyone with kidney problems, even those on dialysis. For Epclusa, it can be taken with or without food, but the critical point is to separate it from acid reducers. It's also a fantastic option, but you need to be careful with patients who have severe kidney disease, as it's generally not recommended for them. So that's a key difference to remember.
So this all brings us to the final and maybe most important piece of the puzzle, our role. Let's talk about the pharmacist's vital role in all of this, because our expertise is what helps these amazing medications actually work in the real world.
Think of this as your 4-step playbook for every hepatitis patient. Step 1, a super thorough medication history. I mean everything, prescriptions, OTCs, herbals. Step 2, screen for every possible drug interaction. Step 3, counsel, counsel, counsel. Talk about why 100% adherence is the only way to get a cure and what to expect with side effects. And step 4, and this is so key for Hep C, emphasize that they have to go back for that final blood test 12 weeks after they finish their pills. That's the test that confirms the cure. It's the finish line.
I know it sounds almost too simple, but this quote really says it all. Adherence and follow-up are everything, and we are in the perfect position to make that happen. For our Hep B patients, that adherence means a lifetime of keeping the disease under control. For our Hep C patients, it's the direct path to a cure. It's that important.
And that brings me to my last thought, something for us all to think about moving forward. We have a cure for hepatitis C. The science is there, the drugs work. The biggest challenge now is actually finding the people who have it and don't even know it. So I'll leave you with this question. As the most accessible healthcare providers out there, how can we help find these undiagnosed patients and get them linked to this incredible life-saving care? That's our next big challenge.